Hi, my name's Joe Bellick, and I'm the founding partner of the law offices of Bellick and Fox. We support the mesothelioma community by providing first-quality legal representation to mesothelioma patients and their families. During these troubling times, we're proud to support the Mesothelioma Applied Research Foundation so they can continue the work that they do every day on behalf of mesothelioma patients and their families.
My name is Kelly Batley.
My name is Clay Thompson.
My name is Neil Mowney.
We are MRHFM, a national firm with 70 attorneys and 11 offices across the U.S.
At MRHFM, we exclusively help mesothelioma patients and their families. It's all we do.
This is why we are proud to sponsor the Mesothelioma Applied Research Foundation and its work to fund mesothelioma research and provide support services and education for patients and their families.
At Novacure, we strive to extend survival in some of the most aggressive forms of cancer through the development and commercialization of our innovative therapy called Tumor Treating Fields. Novacure is pleased to partner again with the Meso Foundation.
Dr. Stevenson, thank you so much for agreeing to be part of this episode of MesoTV. Could you please tell us a little bit about yourself and your connection to the world of mesothelioma?
Yes, thanks, Mary. Glad to be here today. I am a thoracic medical oncologist. I've been in practice and fellowship for over 20 years now, and really my practice has been dedicated to thoracic cancers, and especially interested in mesothelioma. Clinically, I've been involved in clinical investigations of mesothelioma clinical trials during that time, and being involved with groups like the foundation. So it's been, again, something that's like so many of us involved in the foundation that feel passionate about helping people with mesothelioma and their families, and advancing treatment.
So, in fact, we were speaking about you a little bit today on the staff call, in relation to this episode to be filmed. And, I mentioned that, prior to you joining the Scientific Advisory Board, and now that you're a member of our board of directors, prior to both of those positions, you actually had, stood up and volunteered to help us with a number of our reviews. So, you've always been a very strong supporter, and, you've always really looked out for the mesothelioma community in terms of, pushing for really good science and, research and, driving that message home. So I know we've known each other since your days at UPenn, where you held a position in their mesothelioma treatment center, and now you're at the Cleveland Clinic. So what is your position at the Cleveland Clinic?
Yeah, so I've been at the Cleveland Clinic since 2012, and again, a member of the thoracic oncology program here. I lead the mesothelioma effort with some of our, we have a great team of thoracic surgeons here, as well as radiation oncologists that are doing things like pleural radiotherapy. So, we've got a great multidisciplinary group here that, again, we're actively participating in trials, and, again, have tried to carry on some of the work that we were doing at Penn. And here,
and
I'm just going to, and I found that here in Ohio, we do have being kind of in an industrial sort of center of, or what people term as the Rust Belt, kind of a different type of patient with mesothelioma than I was used to in Philadelphia in terms of their background and how they might have been exposed to asbestos. So it's been, to see the cases that we've seen that come from some of the states around Ohio that have worked in automotive industry to steel industry and contractors has just been, again, kind of eye-opening for me too. Just seeing what happens more in some of these, Mideastern and Midwestern states, that mesothelioma is a problem, throughout the country.
And in terms of some of the factory workers and some of the people who had this heavy asbestos exposure, Do you see, did you see also family members and younger patients now in your practice as well?
Yes, absolutely. So we've seen that duplicated in terms of secondary exposures, and then still seeing people with no obvious exposure. Probably 1 out of every 5 or so, where it's not clear that they were exposed. Say, a middle-aged woman with no exposure. What the etiology is. We still have cases like that too.
So, usually when somebody mentions something about, well, gee, my dad had mesothelioma or my mom had mesothelioma, I'm going to find a screening program and I'm going to get myself and every one of my siblings screened. Can you tell us a little bit about, is there screening for mesothelioma? Is it effective? Is it done? Is it approved? Is it covered?
Yeah, there really is nothing that's been found to be effective. It's been tried, and I still will every now and then see patients who, would tell me that they got a call from their workplace, to come in and have a chest X-ray because that was part of some sort of screening program. So those types of things existed in the past, and maybe some still do, but without any evidence that that they had any impact on finding mesothelioma earlier at an earlier stage, or impacted outcomes for our patients. So, unfortunately, as we know that because of the nature of mesothelioma, with the delay from exposure to the development of the disease, the lack of a real precise test, whether it's a radiographic test or a blood test, just has not been a useful way to figure out how to screen folks for mesothelioma.
Right. So it is different though for lung cancer. My understanding is that we pick up early stage lung cancers on these screening programs. And,
Yes.
I think people mistakenly feel when they hear that the unions are doing screenings that they're really, predominantly meant for mesothelioma. But the reality is that they're picking up those early stage lung cancers and an occasional advanced mesothelioma in the process.
Yeah, correct.
So-
there have been some hope that by using certain blood markers like mesothelin or tubulin 3, that things like this could be translated into some type of screening test, but then those haven't really panned out because of just the finding the people who it's appropriate to screen, and then the length of time during screening. You mentioned lung cancer screening. That the study that led to that being approved was just done over kind of a 3-year window where people at risk would have CT scans. And for mesothelioma, where would you find a window like that where screening would be best accomplished? 30 years after exposure, how do you find those people? And it's just really, really difficult, unfortunately.
I agree. So I guess, so when you're seeing people in the clinic, you're seeing patients now who carry the diagnosis of mesothelioma. And, a question I'm asked often is, well, gee, no one told me what stage I'm in. And I wonder, do you routinely tell your patients about stage, and how do you stage your patients? How are they staged?
Yeah, there is formal staging that is done for pleural mesothelioma, not for peritoneal yet, but for pleural there is. It is probably more difficult than some of the other cancers that we stage to give a real accurate stage, because some of it might be dependent on some things that you would find during surgery. We have the T tumor node and M metastasis staging system, what we call TNM, and we kind of put those 3 factors together to come up with a stage, which is a numeric stage, ranging from 1 earliest stage to 4, which is the latest stage of a cancer or of mesothelioma. It does take sometimes more information than we have just with a CAT scan to figure out somebody's stage, although we can, along the way, we can get pretty close to what we feel is the likely stage. But I won't necessarily talk to patients In terms of stage, I think initially, we'll be interested in things like what is the histology? Is it epithelioid, biphasic, or sarcomatoid? And that will help us to know whether surgery might be a consideration, because I think when it comes down to staging, that's probably the foremost thing that we get from it is whether surgery could be considered as part of their treatment plan. And the other factors that come into that, like histology. But then there's other things that we need to consider, like a patient's age, their comorbidities, what other medical issues do they have, things like that. And then at the very end, when we can make treatment recommendations, then it comes down to the patient and their family deciding what's best for them, especially if there are multiple treatment options, and one of which might include surgery. So it's not always as clear cut for mesothelioma, to go from stage to treatment as it is for other tumors like lung cancer, because of some of the other factors that really play a big role in our treatment decision making.
So I think sometimes that also impacts our clinical trial results as well. When we accrue patients for lung cancer trials, we look at all the various stages of lung cancer, 1A, 1B, 2, et cetera. And mesothelioma, it's basically operable versus inoperable. So sometimes when we look at the results of a clinical trial, we don't always know that the patients may have been in later stage disease. So I think sometimes statistics are also a little bit offset by not being able to accurately stage and enter by stage. But with the small numbers of mesothelioma, I just don't imagine that we'll ever get to that point where we would be enrolling based upon stage. I think it'll always be, performance status, histology, and, whether they're operable or not.
Yeah, you're right. It's funny because actually I will have some of our tumor registrars, so the people who officially do cancer staging at a hospital, at a medical center, like they will not infrequently check with me to see what I thought maybe a patient stage was in mesothelioma, because they weren't really sure either. So it's, especially when we're talking about the T staging, the actual extent of the mesothelioma tumor in the pleura, it's really difficult to precisely, say T1 versus T4, some of those categories when we're looking at the amount of pleural involvement. So even the experts have difficulty with that too. And people put a lot of effort into making the staging system. So it's not for lack of trying. It's just the nature of mesothelioma.
Yeah, I mean, the foundation has, we've funded some of the staging work that was done, and, we've been very interested in trying to, further this along. But, as you said, I think a lot of it just has to do with the imaging techniques that we have today and the way mesothelioma grows. Sheets of tumor are very hard to measure, to pick up, versus those shaggy tumors that you see with other diseases. So, so now you have a patient in the clinic. They're relatively healthy. They have mesothelioma. So what impacts your decision on how to treat and, whether to refer them to surgery or clinical trial or standard treatment? How do you make some of those decisions?
Right. And I will just say, as a segue, that, to talk about some of the pitfalls in staging does not mean that we're not able to come up with good treatment recommendations for patients with mesothelioma. So I just want to emphasize that.
Thank you.
That, it is something that a lot of factors get taken into account, and including the input from other specialists, right? But when I'm seeing somebody, and I'm for the first time, and I'm understanding the extent of their mesothelioma, the type that they have, the symptoms that they have, their medical situation, their social situation. I mean, I'm thinking about all those things as when I'm seeing them for the first time and wondering, what's going to be most appropriate for this person. And as we had mentioned, histology will be kind of one of the initial points I go to in my mind to know what's going to be, how aggressive we can be surgically. Number one, I think that's where a lot of us will kind of try to get an initial feel for which way we might go. Is surgery even an option for this patient, a potential option? And that's where histology can help. So obviously with epithelioid patients being the most appropriate for that. And then, if we're going down a more aggressive surgical path, then thinking about things like lung function, cardiac function, other medical difficulties, or not necessarily difficult, any other medical issues. Will it be somebody that a surgeon would even consider for surgery from a medical standpoint? Doing a bit more of a workup to maybe understand if there's any lymph node involvement. That's always critical, usually with some type of what we call invasive mediastinal staging. And PET scans are a part of that as well, especially when we're thinking about surgery.
So Dr. Stevenson, you mentioned the mediastinum. So that question comes up a lot. Could you describe what the mediastinum is and why it precludes surgery?
Yeah, so the mediastinum is an area in the center of our chest where a lot of our major organs and major blood vessels come together, like where our heart is, where things like our trachea is. And around the mediastinum, there are a lot of lymph nodes, lymph glands. And for many cancers, spread into lymph nodes can be one of the first areas that cancers spread to from where they start. That's also the case with mesothelioma. So, so knowing if there is lymph node involvement can help us to know, again, if surgery might be more appropriate, because as lymph nodes get involved further and further away from the pleura, where the mesothelioma is, then the likelihood that surgery will help them, it goes down. So within the mediastinum, since it's in the middle of our chest, there's two sides. There's a left side and a right side. So there's potentially a side closer to where the mesothelioma is, depending on which side that patient's mesothelioma is. And then there's the other side, and there can be spread to lymph nodes in the same side or the opposite side. If it is more towards the opposite side, then surgery is not going to be appropriate. If there is some involvement of the same side, then in some situations it might be. The way that we find that out is there's really two ways. It can be done through a bronchoscope, through putting a scope into the trachea, into the lungs, and you can biopsy the lymph nodes in that way. Also, surgeons can do it through a surgical procedure where through a small incision just above the breastbone, called a mediastinoscopy, they put a scope into that area and they can see the lymph nodes and biopsy them that way as well. So that's again, typically something that we'll want to do for anybody that we're considering surgery to assess whether there are lymph nodes involved, and if they are what's the extent of it? Is it just on the same side as where the mesothelioma is, or is it more extensive?
So that, I guess, really just leads itself to why, patients should be at an expert center, because it's not only the expertise of yourself as a medical oncologist, but it's all your colleagues from the field of radiology, radiation, surgery, all helping to weigh in to come up with a valuable treatment plan for the patient.
Yeah, and again, the more information that we have, the better we can determine the best course. And that gives us a lot more information, even on top of a PET scan, because a PET scan can show us if there are suspicious lymph nodes as well, but it's not definitive, because there could be false positives and false negatives on scans.
And I think historically we always speak about less than 15% of all patients with mesothelioma are operable. Do you feel that's a fair statement?
I agree with that. So for patients that are operable, there is a lot of effort that goes into the preoperative evaluation, and then of course the treatment course. But the reality is that most patients with mesothelioma are not considered operable. And in the patients that are operable, we do look at the procedure as a life-prolonging procedure, not necessarily a curative type of procedure like we do for other kind of earlier stage cancers, say like lung cancer or colon cancer or breast cancer. So the goals of surgery are different in mesothelioma, and that's something that we have to discuss with patients as a group, between all the specialists involved.
I also think too that, we go back 10 years ago, if a patient was inoperable, we probably had less, we had more of a dismal view of their survivability, but I think today there's a lot more in the toolbox. So do you want to talk a little bit about, what you're seeing today and, what sort of excites you in this field?
Yeah, definitely. I think with just in the past year, we've got 2 new drugs approved for use in mesothelioma, 2 immunotherapy drugs that were used in combination in a large randomized trial that were shown to be superior to chemotherapy when it came to, again, life prolongation for people with mesothelioma. So that was a big win for all of our patients. Now it turns out that as we look closer at that trial, that immunotherapy probably works better in some patients and chemotherapy in others. So we don't interpret this trial as immunotherapy replacing chemotherapy, but as an additional treatment that can be used in a patient's treatment course. Because what was found from that trial, what was called the Checkmate 743 trial, was that immunotherapy worked best in patients with sarcomatoid and biphasic histology. And that was something that we were kind of sensing even in smaller studies of immunotherapy. We were sort of seeing that happen, and that confirmed it. So clearly for those patients, immunotherapy is going to be the most appropriate first treatment for them, whereas with the epithelioid patients, chemotherapy still has a role in the frontline treatment for those patients, potentially with another kind of novel drug that we were using before immunotherapy, bevacizumab or Avastin, added to it. So that the incorporation of immunotherapy now provides a novel treatment to use either frontline or second, or as what we consider a second line treatment if people get chemotherapy initially and then need to go to a different treatment. So I think, again, people that are docs that are treating mesothelioma have gained, I think, a good understanding of how to use these drugs potentially in sequence, and certainly the potential side effects, how they might be different, and explaining them to patients. And again, I think putting all this together, it's clearly leading to better outcomes in terms of people living longer with mesothelioma and of course, a better quality of life. The question is,
I guess I wanted to ask you, just, building upon this. So when you have, new patients that you're seeing who've had no prior treatments, how do you decide whether to refer them onto a clinical trial as a frontline therapy? Do you automatically think Alimta, cisplatin, Avastin, Ipi/Nivo, or clinical trial? How is that decision made, and how should patients think about this too?
Yeah, I think if there is a clinical trial available, certainly it might open at the Cleveland Clinic, that they would be eligible for, that's going to be a big part of the discussion. We have a trial here that would offer, say, immunotherapy or immunotherapy combined with, say, chemotherapy, which we currently have. Then, that would be, my first choice if the patient and their family, they were comfortable with that after getting all the information. And in terms of referring maybe for trials elsewhere, that's a discussion that we have as well. And it depends on patients' interest in traveling. Sometimes that makes more sense maybe as a after frontline therapy where we're looking for a plan B, that patients might be more willing to seek out opinions at some other centers where there might be different trials going on. I think thankfully for a lot of the larger frontline trials, like like the Checkmate trial or now for the Dreamer trial, there's thankfully are open at most of the large mesothelioma centers in the U.S. So I think that's important.
And I think, patients who may be listening to this and thinking, well, I can get these therapies at home. I want them to understand the value of that second opinion, the value of seeing an expert in the disease, because even if we don't need you today, perhaps we'll need you, for the second line treatment. So I think getting that second opinion is very important. God bless you. I know you've had a terrific head cold and you're just recovering. I do think that we've covered most of the topics that we had planned on covering today. Is there anything that you wanted to bring up or?
No, I think that we've covered a lot of the things that that I think about when I see a patient for the first time, and we're just getting started, on that journey, figuring out best treatment, and again, it's with experience and working with other experienced specialists, communicating with them, again, generally, despite some of the limitations, say the staging or any other issues, we're able to really, I think, decide what's going to be best, and again, along with the patient and their family being a part of that decision. So,
thank you,
yeah.
Dr. Stevenson, and again, I know the Cleveland Clinic has a well-deserved reputation, and I do hear from patients that they are well taken care of. So I appreciate that, you've dedicated so much of your career to mesothelioma, and I hope we'll also be around to celebrate the rest of these breakthroughs, because we know they're coming.
Definitely. I think now we know that they're going to come much faster than we've seen in the past. So there's a lot to be excited about. Definitely, Mary. So,
well,
more to come.
Thank you. Thank you, and have a good afternoon.
All right.
And thank you again for today. Appreciate
Thanks,
it.
Mary.
Thank
Okay.
you.
See you next time.
Bye-bye.